Hello everybody, my name is Ian Luskin, and this summer I was working with Dr. Richard Baxt at Mount Sinai Hospital's Department of Radiation Oncology. We were performing a study about opioid dependence in radiation patients. So the patients we were dealing with are struggling with cancer of the head and neck region. That's, the nose, the mouth, the throat. And often the side effects of radiation therapy in those areas of the body can cause such severe pain that a patient may even be unable to swallow or get down food, and will experience such extreme weight loss that the only way to give this patient a bearable quality of life is to give him or her a prescription of opioid painkillers. Given the state of the ongoing opioid crisis in America, many patients justifiably voice concerns that they will become physically dependent on these medications during their treatment. And so the question we wanted to answer was, what is the risk of physical dependence on opioids for these patients during their treatment? As you can see in this graph, which I borrowed from a professor at the University of Michigan, opioid prescriptions in recent years, shown by the green line, have been increasing, and deaths by prescription opioids, shown in the blue line, have had a corresponding increase. So it is definitely very valid for patients to be voicing concerns of this type. We performed a retrospective study, which means that we went back through our hospital databases. We identified patients who had undergone radiation therapy between 2011 and 2017 for cancers of the head and neck region. We excluded patients who had struggles with opioid dependence prior to their cancer treatment because we knew that would potentially corrupt the data, and we gathered demographic, clinical, and treatment data on these patients, as well as any information relating to opioids they may have been prescribed during their treatment. In conjunction with a statistician, we ran these points of data through different statistical models to determine what connections we could find with opioid dependence. So one of the interesting things we found was that stage 4B cancer is much more likely to lead to opioid dependence than other stages of cancer. This graph here shows the odds ratios of different stages of head or neck cancer as correlated with opioid dependence. And an odds ratio is basically a number that quantifies the comparative likelihood of one factor being associated with another factor. So for example, if you can see right here that stage 4B cancer has an odds ratio of 3.82, an easier way to think about that would be to say that a patient with stage 4B cancer is 3.82 times more likely to become opioid dependent than someone with a different stage of cancer. We also discovered that certain primary sites of cancer, certain sites of origin for the cancer, were more likely to lead to opioid dependence, namely the oropharynx, larynx, and nasopharynx. So the oropharynx and nasopharynx are up here, kind of at the very back of the mouth and nose, and the larynx, more commonly known as the voice box, is down here, closer to the bottom of the throat. The main point of data we found was that out of all 311 patients included in this study, 12.9% did ultimately become dependent on opioids. Obviously, for a doctor, that's a very alarming thing to hear. And one of the interesting things we found was that out of the approximately 1/4 of patients who did not receive an opioid prescription, not a single one became dependent on opioids. Everyone who became dependent had received a prescription. So within the patients who received a prescription, that's 231 patients, 40 did end up becoming dependent on opioids. So the next thing we wanted to do was determine what risk factors are going to be most associated with the opioid dependence. The biggest one we found was a history of alcohol abuse. Among patients who showed no history of alcohol abuse, only 6.7% became dependent on opioids. But out of patients who had previously or were currently struggling with alcohol abuse, 45.7% became dependent on opioids. That's a very significant difference. The other risk factor we found, not as dramatic but still significant, was induction chemotherapy. Of patients who had not undergone induction chemotherapy, about 11% became dependent, whereas of patients who did undergo induction chemotherapy, closer to 17% ultimately became opioid dependent. So again, to repeat the most salient point of data, almost 13% of patients did become dependent on opioids. It's obviously not feasible for a doctor to be shadowing a patient 24/7, making sure that medications are being ingested only at exactly the right times. So the most important thing we can do moving forward is try to determine the most effective methods of risk counseling and the most effective methods of opioid management. We need to make sure that patients are aware of the ramifications of dealing with such serious medications, and we need to make sure that they know how to handle the responsibilities of dealing with these serious chemicals. So to continue this research into the study, a big thing we would like to do is to incorporate data from multiple institutions. This study was the first of its type, so we started with just data from Mount Sinai, but we'd like to expand that in the future to make sure that we're getting an idea of this problem in a more broad sense. And then the other future direction to take this in is to investigate the countermeasures that I mentioned before, risk counseling and opioid management. So I'd like to finish by expressing my gratitude to the doctors who welcomed me into their workplace at Mount Sinai, especially Dr. Baxt, and also to Dr. Cox, Dr. Murakami, Mr. Abate, and Mr. Ring, who helped me to prepare this presentation. Thank you.
Is there a correlation between either the stage or the location of the cancers and the dosage of opioids that are given by doctors?
So we were not able to pinpoint exactly why the primary sites and cancer stages showed the correlations that they did. So that's something that we're definitely interested in pinpointing in future studies.
Of the stage 4B patients, are they in much more pain and for a longer period of time?
Yes, well, stage 4B cancer is generally considered the most advanced stage. At that point, it's progressed or metastasized throughout the body to a much higher degree. So that could definitely be the main thing playing a role in why that stage of cancer shows such a high link to opioid dependence.
Did you look at the different types of opioids that were being prescribed? Did that kind of come into account?
That's not something we've looked into yet. We know that all the opioids taken into account in the study were prescription opioids that the patients received on the orders of the hospital, as opposed to illegal opioids that they may have acquired through their own means, because patients were undergoing blood work, so we would have known if anything like heroin or prescription painkillers that they weren't supposed to receive would have been on their bloodstream.
Last year in our 11th grade bio class, we talked about these addictive personalities being involved with epigenetics and the question of whether or not they're heritable traits. Was there any discussion of whether a family background could affect the likelihood of a patient's opioid addiction?
So we did gather data on the social history of patients and on their history with substance abuse in their families. We haven't gotten to linking those points of data yet because, as I said, this study is the first of its type, so this research is still in its early phases.
When you say it's first of its type, are you saying with respect to cancer,
When I say the first of its type, I mean that this is the first study that seeks to evaluate the risks of opioid dependence in people who have head and neck cancers.
Cancer. So there could be other studies out there. Are you aware of any other studies that related to other types of treatments? People being receiving opioids for various other ailments?
Well, there are definitely studies related to the links between opioid dependence and cancer in general, but head and neck cancers, especially when treated with radiation therapy, can be some of the most sensitive areas of the body to find that disease in. So this is definitely a very interesting focus to narrow down.
How did you determine if something was opioid dependent?
So dependence, as we used it in this study, is a type of physical dependence characterized by the symptoms of tolerance and withdrawal. So it is defined by biochemical realities within the body and whether or not being deprived of these medications would cause some kind of adverse physiological reaction. All the patients who we described as opioid dependent were still ingesting opioids 6 months after they had finished treatment with a comparable regularity to as if they were still undergoing treatment.
Are there any pain relief alternatives to opioids for similar cancer patients?
As you know, there are many different types of medications that deal with mitigating pain, but the side effects that a patient could experience from this type of treatment is so severe that an opioid is often the only course of action. In some cases, the pain a patient experiences is so extreme that it's necessary to prescribe something as strong as fentanyl.
And I'm sure Ian will be happy to answer more questions